One of the golden principles of trauma care taught by the Pre-Hospital Trauma Life Support course is to use a primary survey approach to identify life-threatening injuries and conditions. Based on the American College of Surgeons Advanced Trauma Life Support course taught to physicians, Phtls uses an A, B, C, D, E format to teach EMS students to do a primary survey that is rapid, organized, and efficient, and identifies life-threatening injuries and conditions. Phtls recognizes, though, that when assessing a real patient on a real scene, the pre-hospital care provider will use all of their senses to assess multiple aspects of the primary survey at once, and that some life threats, such as severe hemorrhage, will likely be observed before others. By using a standard primary survey approach based on the ABCDE format, the provider will quickly take in all that information, sort it out, prioritize it, and begin to develop a plan to manage the patient. Also keep in mind that the primary survey incorporates a treat-as-you-go philosophy. As soon as you see a life-threatening condition, such as major hemorrhage, an obstructed airway, or ineffective breathing, you should begin management of it right away. But don't forget to complete the rest of the primary survey after treatment of the life threat has begun. The primary survey should also be repeated at reasonable intervals during care and transport to evaluate the patient's response to interventions and assess for any other changes in the patient's condition. Once a provider develops their own primary survey, it should be used on all patients, regardless of mechanism of injury, age, or apparent condition. Besides identifying life threats, use of a primary survey for all patients will keep the provider from being sidetracked by patients or conditions they're uncomfortable with, and knowing that immediate life threats have been assessed for will allow the provider to confidently develop a plan to care for all types of patients and the injuries they may have. Follow along as I complete an example primary survey. I will first talk through every step of the survey, and then repeat it, incorporating survey findings in a scenario. While we're en route to the call, we're going to take the information that dispatch gave us, along with any information that we know about the scene or the call location, to try and determine what might have occurred, what types of injuries we're dealing with, what we're going to do about them, where we're going to transport the patient, and how. We would consider additional resources such as a medical helicopter, additional ambulances, and any specialized rescue units. My partner and I would talk about what equipment we're going to take out to the scene with us and who's going to do what when we make scene. We would also consider contacting our local hospital to put them on standby for a trauma patient. As we arrive on scene, we're going to do a windshield survey. From the cab of our vehicle, we're going to look out over the scene to see if there's any obvious threats to our safety, and also see if there's any clues that we can gather about what happened at the scene. Make sure that there's no obvious safety threats at this point. We'd be looking at the mechanism of injury, what exactly happened on the scene, how many patients there are, and again, thinking about additional resources we might need. As we get closer to the patient, we can begin to form a global impression of exactly what's going on with the patient. Do they obviously have life-threatening injuries? Are they obviously in a critical condition? Once at the patient's side, based on the mechanism of injury, someone's going to take manual C-spine control. As he does that, I'm going to assess the airway by listening for any abnormal airway sounds, looking to see if there's any obstructions or potential obstructions such as teeth or blood or vomitus. Then I'm going to turn to the ventilatory status, the breathing. I'm going to do a quick estimation of the patient's ventilatory rate. Is it less than 12, which is too slow, 12 to 20, which is normal, 20 to 30 is too fast, and above 30 is abnormally fast. Then we're going to bare the chest, look for any obvious signs of trauma, any instabilities. We're going to palpate the chest, again checking for instabilities or injuries, and then auscultate with our stethoscope for any abnormal breath sounds. We're going to assess the patient's depth of breathing and effort. If anything out of all that assessment is abnormal, we're going to order oxygen and potentially bag valve mask ventilations. Turning to circulation, I'm going to do a quick scan of the patient's entire body to see if there's any severe hemorrhage that we haven't already noticed that needs to be controlled by manual direct pressure. I'm going to check the patient's pulse at the neck and wrist, comparing the two, and again estimating the patient's pulse rate. Is it too slow, normal, or too fast? While my hand's on the wrist, I can check the skin condition, looking at color, moisture, and temperature. And I can also do a capillary refill. Next is disability, the patient's level of consciousness, If they have an altered level of consciousness, their Glasgow Coma score is less than 15, then we're also going to check their pupils. Expose the patient, cut off the remaining clothing that hasn't already been removed, and just look for any other major injuries that we haven't already noticed. Be sure to cover the patient back up to preserve body heat and prevent complications of hypothermia. At this point, your primary survey is done. Hopefully you've identified any life threats that the patient has. If you did, begin to package the patient immediately and head for transport. If there aren't any life threats at this point, then we can continue a secondary survey and stay on scene and treat the patient's injuries appropriately. We've been dispatched to a scene for a young male who is unconscious after an assault. Since we're 45 minutes by ground away from a level 2 trauma center, we've called for the helicopter and asked the fire department to set up a landing zone. My partner and I had discussed the equipment we're going to take with us to the scene and determined that I am going to do the survey while my partner holds C-spine. As we arrive on scene, we do our windshield survey and see that the police department are on scene. It's a suburban home, no obvious safety threats. The police department meets us at the door and leads us into the basement. As they take us down the steps, they advise us that the patient was assaulted as part of a gang initiation. As we enter the basement, we do a preliminary survey and notice that the patient is a young male, obviously unconscious, with some minor bleeding. My partner takes C-spine control. I assess the airway. I listen for any abnormal sounds, look for any obstructions. There are none. I turn to the breathing. The patient's breathing at a rate of 6 breaths per minute. They're shallow, but there's no increased work of breathing. I'm going to bare the patient's chest. Looking for any injuries. I see some bruising, some abrasions. I palpate. There's no instabilities. The lung sounds are clear and equal bilaterally. I instruct my partner to assist the patient's ventilations at a rate of 10 with a bag valve mask and oxygen. I do a quick visual survey of the patient's entire body for any major bleeding. There is none. I'm checking the pulse at the neck and the wrist. It's fast. It's weak at the wrist. The patient's skin is pale, cool, and clammy, and his capillary refill is delayed. The patient's unconscious. He moans a little bit to painful stimulus, but there's no movement. We'll cut away the rest of the patient's clothing. Assess quickly for any other major injuries. There are none. We'll package the patient on a backboard, cover him back up, and transport him to the landing zone to rendezvous with the helicopter.